Okay, so if the virtual people can give a thumbs up that you can hear us okay. For that. And then, great. Okay, so for those of you who don't know me, I'm Sheila, and I'm happy to introduce Dr. Josh Brandstatter here. So we're lucky to have him here at Penn because he's both a clinician and a researcher. So he sees patients with UCD, and he's also researching UCD. So he's going to be able to give you a lot of information. He has a lot of knowledge about this disease. So we're really excited to have him talking with you today. So I'm going to turn it over to you and let you get started if that's all right.
Absolutely. Actually, our lab is right here in this building.
Yeah. Yep. So you just have to run up the stairs.
Came up the stairs. Nice and easy. Hello. To anyone who doesn't know me, my name is Dr. Josh Brandstatter, as Sheila was saying. I think Gordon is currently
he is
en route, delayed by our current travel situation. I just about my background, I've been in love with immunology for a very long time. So I did a master's in immunology at Oxford. After college, I did an MD PhD at Duke, where I did my PhD on immune responses to viral infection. And then I've been here ever since that, doing my internal medicine training and then my training in hematology and oncology, where I had a particular passion for patients with blood disorders and thinking about how we can harness the power of the immune system to help patients with blood disorders and thinking about how the immune system goes wrong to cause those blood disorders in the first place. I joined up in the lab of a faculty member here who was interested in these sort of questions. And he was interested in a special kind of cell that controls the immune system. And we were interested in other ways that this kind of cell may play a role in human disease. And at that same time, we were talking with David and learning more about Castleman disease. And we're like, hey, maybe this special kind of cell that kind of gets overlooked, that controls a lot of the immune system, may play a role for Castleman. And so I've been working on that project in the lab, and I'll give you a little bit of insight to what that is, about those kind of big areas. And I've been seeing lots of Castleman patients, particularly Unicentric Castleman patients, with Dr. Nasta here. So I see patients with Dr. Nasta every Wednesday afternoon, but I am otherwise entirely in the lab doing research, trying to figure out the questions that we all have about Castleman and have never had a good answer for, which is, what really is it? And what's causing it? What's the root of all this? Obviously, we have patients who have multicentric HHV-A and HIV-associated disease, but beyond that, we're kind of grappling with a lot of what's informed current diagnostics and treatment has been based on a paucity of information about what's ultimately driving the disease, which is why I'm sure just about everyone in this room has had a difficult time with their diagnosis in the beginning, and then probably even with treatment after that because of limited information about what caused it. So today what I'm going to do is I'm going to talk a little bit about where the current understanding of the diseases and the management of disease using slides that Gordon made. So I apologize if it looks like I am looking at his slides for the second time. I just started looking at the slides this morning. And then I'll tell you a little about what I've been doing in the lab and try to make sure there's a lot more time for questions, because I'm very humbled to be a part of this, to be talking to this group of people in particular. What I'm going to be sharing is basically what we understand about the disease from, medical literature, from our own patient interactions, and from what other providers say and tell us they see with their patients all across the world. And that may match your story directly. It may mismatch your story to some degree, and your life experience might be somewhat different from this. We always have to be humble when we deal with a disease that is rare, for which the information is, and about which we know relatively little compared to what other diseases like lymphoma or autoimmune disease, where the Castleman can often get lumped in together. So say that hopefully this will reflect a lot of your experiences, but maybe not. And we understand that we just have to be humble with in the rare disease space, that there are going to be differences that we don't totally understand. All right. So with that introduction, I'm going to try to advance the slide unsuccessfully. Oh, there we go. Okay. As I said, Unicentric Castleman is a rare disease. What I like to start about with what Castleman disease is with when I'm talking with patients is it is a disease of big lymph nodes. And I know Dr. Fajimov spoke about this earlier. So it's a disease of big lymph nodes that look a certain way under the microscope. That's really the best way that we can encapsulate what the disease is. Big lymph nodes look a certain way under the microscope. In the case of unicentric disease, of course, this is a one area, unity area of large lymph nodes that can be typically several lymph nodes, but in one typical lymph node station. Symptoms for most patients are mild. A lot of patients who I meet get these diagnoses completely by accident. They were getting a CAT scan because they got into a car accident or some other reason. Lo and behold, they found a lymph node there that you got them obviously very worried. Or they were having some, I met one patient who was having like a cosmetic procedure on her veins in her leg. And she had an ultrasound that found lymph nodes there that she wasn't expecting to be there and she never felt. And so a lot of patients, and I suspect there'll be not patients in this room, but a lot of patients with unicentric disease have a lymph node. It was found accidentally, and you didn't feel it, or maybe they were starting to feel, especially in the neck region. Oh yeah, it's there. It's starting to annoy me a little bit. They got totally taken out, and then they've been fine. That's a lot of patients with unicentric Castleman disease.
Wow.
Exactly.
Far from all. Exactly. Exactly. This is what I say in all my grants when I'm asking people to fund our research, that there is still more we need to do here.
Absolutely.
The patients, of course, who are not in that description are generally patients who have lymph nodes in tough spots, where the idea of cutting it out is too much of a surgery and there's too big a risk of what they're going to cut around there. They're in sensitive spots as well where they can cause real damage to the adjacent structures that are around, particularly around the big vessels to the heart. They can also be patients who have had things cut out, but then had some degree of inflammatory symptoms that are like multicentric Castleman disease, where they're having night sweats, losing weight without meaning to, fevers, or other different kinds of fatigue, joint pains without meaning, even though they've had their disease resected. And they're also a rare group of patients, typically children, who have autoimmune conditions related to their unicentric disease. And that's what this mouthful of the term is, Perineoplastic Pemphigus. This is a skin disease that affects the kind of the mucous membrane. It causes horrible destruction, make it almost impossible for a kid to swallow and get the nutrition that they need to gain weight. It is a life-threatening complication of unicentric disease. And also kind of goes along with a similar process that plays out in the lungs, bronchiolitis obliterans, where you lose the lung tissue that you need for gas exchange because of an associated autoimmune disease from the unicentric lymph node. We'll talk a little bit more about what that is and how we deal with that. We increasingly understand that the original paradigm of unicentric, one area of big lymph nodes, and multicentric, tons of areas of big lymph nodes, is too simple. And there's even something in between that we were calling oligocentric or regional Castleman disease. This is important to understand because I think a number of patients who I've met have been told that they have multicentric disease when they have maybe two nearby spots. And that's what we kind of think about with oligocentric and regional centric. and regional Castleman disease. Still kind of being ironed out exactly what this is. I can tell you I've been part of a lot of conversations with Castleman physicians from across the world about how we want to really narrow it, how we want to define this specifically. But generally, we think about 2 or 3 areas, usually that are near each other of enlarged lymph nodes. They don't meet otherwise all the criteria for multicentric disease, which requires sort of laboratory test abnormalities and particular symptoms. So some of these patients, again, like they may feel compressive symptoms from where the lymph node is, but they might not necessarily, or some of them do, feel tiredness and night sweats and these sort of inflammatory symptoms. And somewhere in the middle, I meet a lot of patients who the provider who may be completely asymptomatic. They were kind of diagnosed, again, like in sort of accidental way, but they've had their providers count more than one lymph node or more than one lymph node, and they've been told that they have multicentric disease to prepare for the for a prognosis similar to idiopathic multicentric Castleman disease. But they're biologically not that way. They're more similar biologically to unicentric Castleman disease, and that they typically will not present with the kind of inflammatory symptoms that will lead them to the ICU of a hospital. And they will not, and generally their symptoms, with some exceptions, are because of lymph nodes that are growing and causing, pain or damage to the nearby areas. And so this is a new kind of thing that we're defining in between unicentric and multicentric disease, oligocentric disease, more than one spot. The treatment for unicentric Castleman disease, regardless, is complete resection of the enlarged lymph node. So a typical course for a patient would be they develop symptoms or they notice a lymph node that's in their neck. They get one of them cut out for biopsy. It shows Castleman disease histology when they look at it under the microscope. And they go back and get another surgery to get all the other lymph nodes in that same area that were big. And that should be a curative therapy. Patients who have recurrence in terms of the lymph nodes themselves are very, very few. It's kind of like in the single-digit percentage. That said, some patients continue to have inflammatory symptoms after the complete resection. And that's one of the unmet, I would call, areas of unmet medical need that we're currently working with right now. The most important then treatment, since the first line treatment recommendation is surgical resection, the first way we bucket patients is whether or not they can have their nodes taken out safely or they can't have their nodes taken out safely. And sometimes this is part of a shared decision-making process with the patient that maybe they can be taken out, but it's a big abdominal surgery. It's where their lymph nodes are. And we have to talk to patients about what their own personal risk benefit is based on how much symptoms they're having from the disease and their long-term comfort with having these lymph nodes, these growing lymph nodes in their body versus the morbidity and the side effects of having this, like a major abdominal surgery. And then sometimes, of course, it doesn't matter whether the patient wants the surgery or not. It's just not in a place where we can safely take out the lymph nodes. And it's another area of unmet medical need for unicentric Castleman disease. Although I'm going to talk a little bit more about some of the tricks that we use to try to make something that was deemed unresectable resectable, to shrink it so that a surgeon can take it out. I've already talked about a lot of these issues, and I'm very glad that Gordon threw this important point about some unicentric Castleman patients remain symptomatic after surgical excision, because this is something that, as I said, is a big area of unmet need right now. You see the Castleman disease also include on is that the Castleman disease collaborative networks, treatment, surveillance imaging recommendations following complete excision of a yearly cross-sectional imaging either by CAT scan or PET scan in addition to looking for blood work for biochemical markers of inflammation up to 5 years after surgery. And again, some of this practically can be part of a shared decision making with the patient in terms of their comfort and their interest in following up. But we certainly recommend at least an annual cross-sectional imaging and blood work every year for 5 years. One of the tricks for patients who are not able to get the lymph node completely cut out is a debulking surgery. This can be particularly important for patients where their lymph node is in a sensitive area. There's no way of cutting it out entirely safely, but we're worried about if it continued to grow, it really causing big problems. Or maybe it's already starting to cause big problems, especially if it's near, outflow tracts from the heart with near major vessels. And so the idea is a debulking surgery where you just make it smaller, cut it to make it smaller to give the adjacent structures some room again. That's one strategy that you can use for patients who are not completely surgically resectable. Embolization is a procedure whereby you are able to block the blood supply to the lymph node. These lymph nodes in particular, Unicentric Castleman lymph nodes. If you look at them in the microscope, you see a lot of different blood vessels. They're very dependent on having a fresh supply of food and lots of food. This is what they're doing. And oxygen is what they're using these vessels for. And so if you can cut that off, you can help shrink these lymph nodes. So that's another approach that we can use for lymph nodes that are not fully surgically resectable. And then rituximab is another treatment that we can use upfront before for making a patient who might not otherwise have a lymph node that can be cut out by itself to shrink the lymph node, either just to provide some symptomatic relief or to just help maybe make it, taking it from unresectable, shrink it so it then becomes resectable. Rituximab is an IV infusion, and I think probably a lot of people in the room may be very familiar with it, that whereby you have a monoclonal antibody, is not a chemotherapy, that recognizes a protein on the surface of a kind of white blood cell called a B cell and tells the rest of the body and the immune system to go clear it out. This can shrink a lymph node because a B cell is mostly what's in a lymph node. So by clearing out those B cells, you can really shrink a lymph node pretty dramatically. We'll talk more about rituximab in a bit. This is a point that I already made. I think people would talk about what to do for patients who do not have resectable disease. And this is part of a shared decision making, whether or not they're having symptoms or they're not having symptoms. Do we think it's in a place where if it just grew a little bit, they will start having symptoms? And how do they feel about treatment in general, based on how their tolerance for they're absorbing the potential toxicities of any treatment versus dealing with the presence of this mass they're being long term. Some patients, will be completely asymptomatic. I don't want to have any treatment that's going to, that could have a side effect to it. And their opinion would be, I'm okay with this thing in my body, and we're just going to watch it for. And that's a decision a lot of patients make, especially unresectable disease. And even some patients with resectable disease choose that, especially if it's, I would say a younger patient and it's like an abdominal surgery. This is talking about strategies using medications to help patients who have unicentric Castleman that cannot be cut out. So I've already talked about Rituxan, an immune-based therapy, an IV infusion that shrinks lymph nodes by telling your body's immune system to take out the cell that is the most common cell in the lymph node. Steroids are another way that lymph nodes can shrink. Generally knocks down the immune system. It's a big pop on the head of the immune system. I'm sure a lot of patients have experiences with steroids. magic drugs that aren't. And then we can also consider patients whose symptoms are not due to, I got pain in this one spot because the lymph node's getting big, but are due to associated inflammatory symptoms. So they're, they might have one area of big lymph nodes, but they feel to some extent like a multicentric Castleman disease patient in that they have those inflammatory symptoms. Drenching night sweats. I tell every patient, you're allowed to feel sweaty when you wake up at 3 in the morning to go pee. Everyone feels that way. But if you're, oh my gosh, changing sheets and your clothes, that's a drenching night sweat that we consider an inflammatory symptom related to a Castleman disease or lymphoma. Unexplained weight loss, profound fatigue. It's okay to feel tired. But if you're really napping to get through the day, not able to get yourself together to do the things you need to live, that is a fatigue that we need to think about starting medication for. And unexplained fevers as well. Sometimes just also I would call these diffuse joint aches as well, fit with this inflammatory symptomatology that can sometimes go along with unicentric Castleman. And for those patients, as I said, it kind of mirrors multicentric Castleman disease. So we use a treatment that's been developed for multicentric Castleman. It's the only FDA-approved medication for Castleman, Symptomatology, or its cousin drug that works in the same way, tocilizumab, that blocks IL-6, which is an inflammatory cytokine. It's a way white blood cells get themselves excited and start telling themselves, we're going to war. And so it's a way of blocking that and telling them to calm down. So that is another option for patients who have disease you can't take out, or even patients who do take out and they're still having some inflammatory symptoms. Consider Symptomatology. And for those patients, and you can also consider, actually, even for patients who don't respond to Symptomatology, you can then consider rituximab as well, because some patients who don't respond to Symptomatology can then have responses to rituximab. And there are other immune modulators that I didn't talk about, such as cyclosporin, which is kind of like a cousin to steroids in a way, but it's a drug that is safer than steroids for staying on in the longer term. And sirolimus, again, a cousin to steroids that's safe to be taken in for a longer term. It's actually originally a transplant rejection method. I'm sure Dr. Fajan will talk about more at this point. And then we have an active clinical trial for here at the University of Pennsylvania and at the University of Arkansas for its use in idiopathic multicentric Castleman. Okay, I think I said this stuff already. By using these tricks to make an unresectable lymph node resectable. The boy has some beautiful pictures showing very scary looking masses near very important blood vessels. This is probably since you see how prominent all the vessels are with the contrast dye, this is probably during an embolization procedure that they would do it. Radiation therapy is something I have not talked about, but it's something that we can use as well. A major side effect of radiation therapy is that anything near the lymph node can also get damaged by the shooting of light particles or protons at the target. So anything around it would be at risk for causing damage to those structures. That's the major side effect of radiation. It's focused treatment, and anything near there can also be at risk for being damaged. Not as well used for unicentric Castleman disease, but certainly a tool that's in our pocket that we need to can. I would say for patients who are not resectable, who are not getting responses otherwise to some of the treatments that I mentioned, I think it's, and particularly patients who are symptomatic, I think it makes sense to at least explore that conversation with the radiation oncologist. And the center here, like a large place here like the University of Pennsylvania, it's very easy for us to even just have those conversations with colleagues and about how they would do it and what they would consider as being possible side effects, because that obviously will inform any patient's decision. That's kind of individualized based on where these things are. This is a nice clear diagram talking about some of the things that I was just kind of saying without having a nice picture here about how some of these medications work. He does not have a picture of how the testing works, but he does show here how IL-6 blockers, whether it's siltuximab or tocilizumab, can help patients with calcium disease. So this is a signaling molecule. It's produced by some cells to tell other white blood cells we are going to win. And that's part of how I would talk to patients about calcium disease, Negan disease, of big lymph nodes that look a certain way under the microscope. And what that way is under the microscope is it looks like the cells are going to win. You have lots of different blood cells, and I think David talked about that this morning. And some of those are first responders, police, firefighters, EMTs, that are there at the scene of the infection, the germ, whatever, lickety split, no matter what the problem is, they're there. There's some white blood cells that are members of the military. They're not there right away. Oh boy, and they live in their bases, which are the lymph nodes. They're called lymphocytes. And that's what we see in Castleman disease, that it looks like they're getting ready on in their base for a war. And this is one of the molecules we know in Castleman disease they use to get themselves hyped up and get themselves prepared for war. So this is part of what we've been using very successfully for at least a very high percentage of patients with multicentric Castleman disease, is blocking this pathway helps patients do well. And you do it by this one medication that blocks the actual molecule itself, and another one that blocks the receiving part of that. You can see that he mentions other parts of the signaling pathway that happen to excite cells and get them ready, tell them to get activated. And these are all active areas we've been exploring for additional therapies for calcium patients. A lot of these have right now been under consideration for multicentric patients, because those are the patients who are more profoundly in higher number presenting with these severe inflammatory symptoms. But I suspect over the years, we're going to see more of them come toward help unicentric patients, specifically the ones who are having inflammatory symptoms that are not being helped by the other. Side effects. I mentioned side effects of radiation therapy already. I feel silly telling this room about the side effects of corticosteroids, right? Weak at night, anxious, eating. If you're on it longer, skin can start to get really frail and get all bruises over your, get fluid in your legs. Any patient who's close to having a blood sugar problem can all of a sudden really have a blood sugar problem with higher enough doses of steroids. Maybe you just, you don't like the person you are on steroids, or your family members don't like the person you are on steroids. But they can be magic drugs despite all of that, because they can help someone get control of their symptoms of the disease in a pinch. So I think particularly for short term, when someone's like, I'm not good, we need to turn this ship around very quickly, that's a really good choice to help people get some control over things fast, even though it might not be a long-term option. Going in reverse order here, siltuximab can cause infusion reactions. There's some blood tests that we have to follow, risks of infection. Generally, patients do very well with them. Some patients don't. They have trouble tolerating siltuximab. Rituxan The major risk is infusion reactions, allergic type reactions that can happen at the time of infusion. Patients who get them usually get them the first go round. Sometimes not, but usually it's the first go round. And that's why the medicine is given with pre-medicines that are anti-allergy pre-medicines. And it's given the first time very slowly. As anyone who's had their first Rituxan infusion knows it took 3 hours or so to administer.
A lot longer than 3
hours.
Oh yeah.
Yeah.
5.
I
had to stop it.
Mine was stopped several times too.
Yep.
Yeah. Fortunately, not uncommon. It's one of the major problems of Rituxan. But if you get through it, afterward, it can be a good option that is generally very well tolerated. Although we have to think more about the use of Rituxan now in the COVID era. Definitely takes away one of your body's defenses against infection, which can be important for COVID, the response to COVID viral infection. And right now, we would give patients Evusheld or some other monoclonal antibody infusion to try to make sure that they have protection while they're administered the rituximab, or we can demonstrate their antibody levels already work very high against SARS-CoV-2.
How often would you get the Evusheld if you're on ongoing Rituxan?
If you're on ongoing Rituxan every 6 months, I think is what the current recommendation is for Evusheld, unless you demonstrate antibody responses to SARS-CoV-2, in which case it can help them a little bit well. I'm not completely sure what we were trying to accomplish with this slide, other than really mentioning there is a variation of ways people present based on where the lymph nodes are, what they're next to, whether they're resectable, and whether they come with any other things, any other symptoms that are not directly related to large lymph nodes and compression. I was looking at this morning. I think you forgot to finish this slide. I'll talk about it. PNP is Perineoplastic Pemphigus. I was trying to talk about one of the autoimmune complications of Castleman disease that I said was so horrible that causes these horrible mouth lesions and can even involve the lung with bronchiolitis obliterative. It's an autoimmune disease associated with Unicentric Castleman disease. Now, I'm sure, as Dr. Vajima mentioned, Castleman is kind of at this weird nexus between malignancy and autoimmunity and somewhere in between. But Castleman disease, you don't think about as being a malignancy in the same sense. There's not one cell that's made a bazillion copies of itself. When we look at it under the microscope, that's not what you see. You see white blood cells going to war. You don't see all one kind of white blood cell making copy after copy after copy after copy. That's a lymphoma by definition, if it's a lymphocyte. You also don't have autoimmunity in the traditional sense, because it's not like rheumatoid arthritis where it's just attacking the joints, or it's not, or multiple sclerosis where it's just attacking the central nervous system, or ulcerative colitis and Crohn's disease where it's just attacking the gut. The immune system's activated, but it's not really going after any one thing in particular. It's creating an inflammatory milieu. It's getting angry and which can cause symptoms in terms of inflammatory symptoms, but doesn't attack specific areas like an autoimmune disorder. That's not this. This is a straight autoimmune disorder where now you have white blood cells that for some reason getting a disordered message back from the unicentric Castleman lymph node are going to attack the lining of the mouth, are going to attack the lungs. This is a deadly complication of unicentric Castleman disease that happens mostly in kids. I'm trying to think if I've ever seen an adult with it. I'd be interested if anyone's had that experience, but I think fairly exclusively in children who get this complication. We recommend getting the node out immediately, and that will help patients, but oftentimes they do still need some sort of adjuvant treatment, something like Rituxan and high dose steroids to try to get this under control. This is something that can be fatal for a young unicentric Castleman disease patient. So it's important that this was mention on this slide. We had a case recently at Boston Children's.
Have you spent time studying the complement cascade in Castleman's patients and acquired AH50 depletion and activation of the C3 and other?
That's such an awesome question. So you're talking a little bit about some single cell RNA-seq, bulk single cell RNA-seq that shows some activation of complement cascade in the context of Castleman.
Yes.
Yeah.
And also the monoclonal gammopathy presence of the real study.
Those are, I would consider those two separate things, right? For the complement, it's something we've been studying and seeing in a lot of the bulk single cell RNA-seq. I am personally doing some single cell RNA-seq, right, where you not only see what's being expressed by the whole tissue, but what's being expressed by each individual cell, which is kind of cool. It gives you like a much more higher resolution picture of what you're seeing in the lymph node. I think those are mostly coming from blood vessels. I haven't published this yet. I'm about to do this. It's coming from blood vessels. And the question then becomes, which I'm sure everyone is this intervenable? Or can this, and this is what I think no one has shown yet, is, although I think CHOP has some experience using like eculizumab, a complement cascade inhibitor in patients with Castleman disease. But no one knows for sure whether this is like a cause of inflammation or a downstream consequence of inflammation.
And some doctors are saying there's no relation to Castleman. I really don't know.
Oh, I don't think anyone said it. Right now we have.
Oh, I've had doctors say that it's not related to Castleman.
Oh no, I think there's certainly evidence that it could. Yeah. I wouldn't say that categorically at all. No, I would not say that categorically. It's an idea. The question with a lot of where Castleman research is right now, it's chicken and egging thing, right? And even does it matter, right? Because let's say it is a manifestation of inflammation. You're still dousing a flame, right? So maybe it wasn't the root cause of the fire, but it's still on fire. And by putting it out, patients can get some relief, right? Yeah, that's exactly right. So that's how I would feel about
y'all
that.
studying it? I mean,
I'm not aware of anyone who's doing a systematic attempt at looking at eculizumab. All I know is that CHOP has treated a few patients with it, and I know they like it. They haven't published a series of what they've actually gotten at. So that's where I know that drug is right. The monoclonal gammopathy, I think about that traditionally with like poems, right? Which we generally don't see with unicentric. And it would also be tricky because it's also common, right? If we started going down the streets to Philadelphia and, forcibly sticking people and testing their SPAPs, we're going to find a bunch of people with positive, right, proteins. But the patients who I do see typically have very low positivity. And when they have bone marrow biopsies, they're negative, which is good, right? And I suspect what you're seeing is the sort of disordered manufacture of an antibody. And it's not quite, since the patients don't have typical and if they did, this would be, of course, an exception to this, but generally the patients who I think don't have these sort of typical myeloma-like symptoms. So I wonder if this is just an irrelevant protein that they're making. But you always have to pay attention if they are starting to have poems-like things or myeloma symptoms, and you have to make sure they've had a bone marrow biopsy to really look at the factory floor and say, yeah, is there some plasma cell that's making copies of that and manufacturing this stuff like crazy? So that's where that's at. That was helpful. Okay. I think we've talked a little about the importance of evaluation for resectability, symptomatology, what to do for different kinds of symptoms, inflammation symptoms, compression symptoms, tricks to make non-resectable patients resectable, and other tricks for inflammation for patients who have stubborn inflammation after their nodes have been cut out. With the idea that this is an obviously evolving area. Some patients who've been in this bucket may be on medicines that are not on this list at all. because some of this has been dependent upon providers making personalized decisions for patients, which can always be tricky then from an insurance standpoint. That's one of the struggles, of course, with rare diseases is having insurance approval when there's just not going to be that high level data to support its use for a particular indication that we can get for common diseases like lymphoma. I think these are wonderful points that I think everyone in this room is likely very familiar with. I cannot stress enough the importance of having it, of being seen in some way, shape, or fashion by a Castleman disease provider, by a provider who has experience with Castleman disease. I'm fairly confident that almost everyone in this room has been in a situation where a provider has said to them, "Oh, you're the first person I've seen with Castleman disease." Mm-hmm. A lot of patients are not reassured by that. And I agree. I would say that there are a lot of very wonderful hematologists, oncologists out there who will have long and successful careers helping lots and lots of patients, but will have not treated very many, if any, Castleman disease patients. And so finding someone who has more experience with Castleman disease can be a challenge, but is certainly the right path to at least have some sort of way of touching base with that person. We like to think that we're great here at the University of Pennsylvania, but I know that there are a lot of great providers at other institutions as well who have similar passion for helping patients with rare disease, similar passions for helping patients with Castleman, and are equally clued into all this larger ecosystem that's been developed largely by Dr. Fajgenbaum for learning more about Castleman disease and sharing everyone's experience together so we can find new treatments for patients who feel like they've tried 12 different things and they're at the end of the rope without getting relief. And so touching base with them, I think, is important really as soon as you get this question even, because as I tell a lot of patients, not even just the doctors you see that have more experience, it's also the doctors you don't see, the pathologists. They're the ones who make the diagnosis of Castleman disease. They're the ones who looked in the microscope and said, "This looks funny. This looks exactly like the problems I would see in Castleman disease." Just like the doctor you see might not have experience with Castleman disease, that pathologist might also not be comfortable, might not have just seen enough cases to know what is Castleman and what's not. And I think having even your biopsy read at a high volume center where they see more Castleman disease is worthwhile when this question gets raised, to get their interpretation of whether the disease, whether what they see in the microscope fits into this constellation of findings that fit with Castleman disease or not. And then as I said, just touching base, one-time visits are fine if you just want to make sure the plan is all sorted, and then touching base later as problems come up after a plan gets started with the Castleman experienced clinician is a good strategy, because sometimes we're in cities where parking, travel, and traffic and everything is pretty inaccessible. So making sure that you have someone on the ground who you like, who's near your home, and then someone maybe from far away who has experience that you can see less frequently and can help touch base and just provide a sounding board for questions as they come up with the care. Someone who's met you, laid eyes on you, done an exam, knows you. This room also knows that we take night sweats, fever, poor appetite, weight loss, just pain that's profound, perplexing, and progressive. It's there, it's getting worse. I don't understand why it's there. It's still going on. Didn't just get better with a little bit of Tylenol. And I'm feeling it now days later. New skin lesions should always mention these to their provider. There are a lot of symptom-specific treatments we have. And then I think I'm going to probably try to tidy this up, because I think this group probably knows a lot of the common, these are just the lab values that we see being disordered in Castleman disease in general. I will actually focus, I do like this part though, because I think this is really important. Number one question I always get asked by every patient is, what should I eat? Is it something I ate? And the internet suggests lots of inflammation diets and, everyone sees, we all watch the same news where one thing's pronounced healthy one day and not healthy the next day. And honest answer is there's no diet that causes the disease. There's no diet that we know of that makes the disease symptoms better, that anyone has shown that's been true for lots of different Castleman disease patients and has been able to show this in like a reputable journal, or other people were able to say, oh yeah, are they really Castleman? Can you really prove that their disease got better? Nothing has hit that high quality of evidence. Healthy diets are important ones, that are protective of cardiovascular health. Mediterranean diets that are low in processed foods are important. There's some suggestion that that can help patients who have different kinds of inflammation. But beyond, and for patients who are going to be more severely suppressed, then avoiding foods that are higher risk for foodborne infections can also be advised. But even patients on Rituxan, for example, can have sushi if they want. Patients who are getting chemotherapy cannot have sushi. Patients who are on Rituxan should be able to safely eat that. And so there's not any restrictions other than making sure you're having a good, healthy diet. I would suggest high in protein that helps build good, important muscles so that you can, especially if you're dealing with weight loss related problems, you can help maintain good, healthy body mass and throughout the worst of your symptoms or treatments. Exercise helps for sure. Regular exercise, exercising, like it can be low intensity exercise, just walking a couple of miles each day can really help with a number, and this has been shown across diseases, particularly for cancer patients. If the cancer patients on chemo do better with daily exercise than cancer patients who don't, who are otherwise identical patients, there's something about exercise that helps, and I think it's going to, and I don't think that's just specific to cancer patients. I think it's going to help everyone just make symptoms better in ways that I don't have, as a lab guy, I don't have a great biological plausibility, but we know works. And the psychosocial adjustment and the psychological toll that the physical illness has on you is an immensely important point on this that we always put at the end of the presentation. Probably should be at the beginning because it goes hand in hand with everything. Symptoms are always worse when you feel worse, when you feel bad. Doesn't mean that they're the cause of the symptoms, but you're going to feel them more when you feel anxious because you're unsure about your health future or what your health means for your family members or loved ones who are caring for you. And when you're not able to sleep, whether it's because of steroids or not. Whether the health issues that you're having are preventing you from keeping your job, which has been always a part of keeping you even keel, or always a part, something you needed to do financially. These cannot be overlooked, and making sure that we're doing something to address these. And we're doctors, so we always think about medicines, but that's what we have. To help, that's our area. It's what we train in medical school, is how to use medicines to help people. But this is much bigger than that as well, and can go beyond what your clinician might be an expert at doing in terms of finding things to help you to feel even keel, whether that is psychological support by talking to people, cognitive behavioral therapies, again, diet, exercise, and using other sort of stress coping strategies are, an integral part of everyone's life, but, have an even bigger meaning for anyone who's dealing with the disease, especially one that's not, a rare disease where They went through so much just to get the diagnosis, and then still dealt with more issues even after the diagnosis. And that was the extent of forwarded slides about the treatment.
Josh, would you like to go into some questions on those slides, or do you want to go through the research first and then end with?
I'm happy to do whatever anyone wants. Does anyone have any burning questions you want to talk about right now, or should I just do a few more slides on some of the things I've been?
Have you found any other autoimmune diseases that are, I don't know, for lack of a better word, prolific amongst UCD?
It's a great
Or
question.
is anyone looking into it, like with the Accelerate and everything, to see what other symptoms and things and diseases people are dealing with? And is there any connection?
Yeah, well, you're the accelerator.
I am the accelerator.
I knew I was asking the right person.
Yeah, so we do have an autoimmunity study that we are looking to whether or not there is any associated autoimmune changes. And then we are also collecting all this information for Accelerate. So the idea being that if for all the patients who enroll, we're going through those medical records and looking to see if their physicians have diagnosed them with some other, lupus or some other autoimmune disorders. And then we can look for an association between patients with Castleman disease and those disorders. So we haven't yet found anything there, but it is something that we are hoping to do in the future when we have enough of that information.
That's awesome. And this is what I think has been so cool about the CDC and bringing together everyone's experience, patients' power to share their experience as part of this registry. So it's not just these little fiefdoms of whatever interested,
Right.
physicians there are at every different institution doing their own little thing in their little worlds. We're all working together on the same page to try to sort this. There are like a lot of these sort of questions, especially sort of epidemiologic questions about associations. There's no way of answering this outside of something like Accelerate. Yeah. Because even a place like Penn, where we see a lot of Castleman patients, no one has that big a panel that they can answer some of these big questions about associations without that.
And then we have some questions come up online, but
cool. Good, you want to do it? That's fine.
So there was one question that came up early on when you were talking about inflammatory symptoms post-resection, and can you define what you meant by inflammatory symptoms?
Sure. By inflammatory symptoms, I would say traditionally I mean drenching night sweats, unexplained fevers, unexplained weight loss, profound fatigue, diffuse joint aches and rash.
Okay, great.
Sometimes it can also be muscle aches too.
Okay.
And swelling and sometimes lower extremity swelling too.
Okay.
Yeah, I have a follow-up to that.
Of course.
So when you're going throughout the medical community and you're trying to get this Castleman's diagnosed, that's kind of a really, really frustrating period of time, right?
Yeah.
So everybody's taking blood, doing blood transfusions, and everybody says, "Oh, you got inflammation here," but nobody has an answer to that inflammation. But you got inflammation. Again, nobody knows where the inflammation's coming from. Yeah. At that point, who takes the R? When you're MD.
Yeah.
I'm looking, you're my MD, and you say, you got inflammation. And I'm like, okay, what does that mean? And I think that's part of the frustration with this diagnosis sometimes is you're given, I'd be lying if I said we weren't given information, but nobody was put it together.
Gotcha. Okay. So what does it mean by saying inflammation?
Yeah, so what does, as a follow-up to that question?
Yeah, that's a good question because I'm going to keep coming back to this idea of the disease being poorly understood. What exactly is going on in the lymph node that causes those characteristic changes?
Right.
So I think about patients who have inflammatory syndrome associated with unicentric disease in two ways. Okay. One is a patient who they're telling me they're feeling what I would call these classic symptoms that I just described. And they also have biochemical markers of inflammation in the blood. Okay. So when I check their blood, and when I check their blood, I see the sedimentation rate is up. That's just a general inflammation. So it means that, you know, it can be activation of the complement cascade and other these sort of immunologically active pathways that are up in the blood. It doesn't tell me what causes inflammation, it just tells me it's up. CRP works slightly differently, but goes hand in hand with that. Okay. We also check, obviously, on patients IL-6, which can sometimes be up.
Yeah, I've seen the 6 number.
VEGF levels can sometimes be up as well. There are other ways that inflammation can be felt by the rest of the body that we sometimes see with Castleman disease, particularly multicentric, but can sometimes with unicentric Castleman. You know, abnormalities in blood counts, higher white count, lower white count, lower red count, lower platelet count, higher platelet count. Liver, kidney numbers being up a little bit can also fit with inflammation. So that's one group of patients with unicentric disease who feel symptoms that I would call classic and who have these numbers that are off. And I think about this in the same way as multicentric Castleman. Even if the severity might not be the same, right? Like they're not in the ICU, but they still feel awful and not able to live their lives. And I think about that. I don't know what's causing that, right? Because the lymph node was taken out. Where is it coming from? Something's funny going on in their immune system, and I don't have a good explanation for that. I will tell you that I'm very interested in that. Like, I'm going to fall over here. And I know that Penn is getting behind this in a bigger way too, that I hope in the next few years or sooner, I'd like sooner, we're going to have a more systematic way of using techniques that we built in the lab that we use for research all the time and start applying them to people and seeing in a higher, in a more complicated way what's going on. So for someone who was asking me more like science-based questions earlier, I'll say we're trying to find ways of using like some sort of high parameter mass spec or high parameter flow cytometry to better characterize the immune system without just using these clinical tools, which are fine, but are vague and not like what's going on. Don't answer that specific question that you asked me. These are just common things. They're, you know, insurance makes them cost a lot, but they're not actually that expensive, right? These tests, right? They're low-tech stuff that they're Walkman technologies, right? And use stuff that we can do now and actually use this to solve this problem. And this is something I really want to do. It's something I know that I had conversations with Dr. Fajenbaum and other faculty members here at Penn that they want to, if the will is there to look into, to more specific, and that's one of the things we want to do.
That's kind of what I'm doing.
There's another group of patients, of course, that maybe their symptoms are classic, maybe their symptoms are not classically inflammatory symptoms, and they don't have any increase in the numbers.
What about the numbers that they're not looking at? There's some numbers that are showing up in specific cases. Like the complement is not something somebody automatically orders, right. But should they be ordered in everybody that is in the oddball case? So where they're already having the night sweats and they're already having all the flu-like symptoms?
Yeah, so C3, C4 levels are traditionally not checked with Castleman. Some people do check them though.
If you're sent to an immunologist,
I often would try to check them in because we think of them typically with rheumatologic diseases, even though they're just inflammatory markers like anything else. A lot of these things, since they're all fairly, low resolution vectors, like they usually go hand in hand with each other. The idea that you see specific changes in complement, and complement actually typically goes down with inflammation, even though the RNA-seq data suggests there's some increase in particular other kinds of complement factors that go up.
The AH50, the CH50, the factor B, the factor.
Yeah, exactly. And whether these, and those are both RNA-seq, remember, of lymph nodes, whether these are detectable in the blood, no one will show.
But
in fact, someone did a great proteomic screen and did not see.
Complement?
Yeah.
They weren't one of the, I think we did see C3 up,
okay.
but it wasn't one of the highest.
Gotcha.
And then, sorry to, as I'm going to break in, we're at 12:37, so we could go back to slides, and we do have the time for Q&A later this afternoon as well.
Yeah.
That makes sense.
Okay. So I agree. I think it's worth checking.
On those oddball cases.
Because it's
research.
yes, and those patients are always going to have a frustrating time because it's hard, right? We don't have a number to follow. Like we like having a number to follow to make it for imaging, right? That shows, yes, it's getting bigger, it's getting smaller, the number's going up, the number's going down. It's harder, it's more challenging for those patients. And now sometimes they still benefit from similar therapies right now, but they're also worthwhile thinking of them as even a separate group that require greater characterization. So I'm going to talk about a little bit of some of the extra stuff there. And this is my way into the Castleman world. Before I started treating Castleman patients, I told you I've been interested in immunology for a really long time, and I joined a lab that was interested in graft versus host disease, a serious complication of bone marrow transplant. And they were showing that where the transplanted immune system winds up attacking the whole body of the recipient. Horrible, horrible. Kill a lot of people who get bone marrow transplants. And what that investigator had shown was that the disordered signal was coming from not the white blood cells, that's basically 95% of what's in a lymph node, the white blood cells. The military are mostly what's in the white blood cells. But basically, it's coming from these cells that are kind of like the structure of the lymph node. They're the walls of the lymph node. They're not just static walls, they're talking, and they're giving survival signals. They're telling white blood cells where to go. They're telling them whether to go up, whether to get activated or to calm down. And they're different, and they're actually ton, even though we're talking about like anywhere from 1% to 5% of what's in the lymph node, there are tons of different kinds of them. And they act as sort of air traffic controllers. And when I joined this lab, I was kind of interested in how else these cells may play a role in human disease. And we thought about Castleman disease as being a case where, a lot of people look at white blood cells a lot. And they're certainly angry and they're certainly inflamed, but it all looks very general. Every sort of characterization they've done of the white blood cell inflammatory picture, no one said that this is a specific signature for Castleman disease. Even when they've done high-profile flow cytometry of multicentric Castleman patients in the blood, they publish, David's group has published increases in interferon signature. But whether that's a specific thing for Castleman or they're just calling that inflammation, not quite clear. And so it doesn't get at what's the root cause of things going wrong. And so we're asking the question, are these kind of air traffic controller cells of the lymph node the root cause of what goes wrong with Castleman disease? These stromal cells, a lot of people have shown lots of roles for them in autoimmune disorders, cancers, providing kind of like being the boxing coach for a lymphoma. They can kind of help, comfort them, give them strategy and advice for getting around the chemo. And we were wondering, are they important in causing unicentric Castleman disease? And what specifically got us interested in this was there were a couple of papers that came out recently that actually suggests that there could be some degree of clonal growth in unicentric Castleman disease, where there is a cell that, not in the same way of like a lymphoma, where it's like, you look at, oh yeah, there's just tons of white blood cells and they look all the same to me, but they're but a similar kind of one cell dividing too many times, making too many copies of itself. So one group used this older trick of looking at showing that the cells are copies of each other to show that in unicentric Castleman cases, but not in multicentric cases, they can see, depending on the exact technique, they can see about half to 3/4 of the cases, they can find this genetic evidence that the cells are identical and they're growing as one cell, making lots of copies of itself. And the question is, if it's a stromal cell that's doing this, could that cause inappropriate accumulation of white blood cells and drive inflammation? If a stromal cell is making a few too many copies of itself, or, changing the balance, could that be causing now this inflammation in that lymph node? because it's disordered the regulator signal, the air traffic control signal. I've been starting to do this work where we take lymph nodes from patients who have donated them, pieces of them, and we cut them up into small pieces. We enzymatically digest them to remove these stromal cells from the extracellular matrix, from the gunk of it, get these cells out because these are part of the walls. We can remove these cells from the walls, and then we can actually identify very specific groups of these different kinds of structural cells, and stromal cells. And we even now develop strategies, we're about to publish this, where we can do this in a much more higher throughput way and start to freeze down tissue to get it out later. Because before we were doing this all fresh, which is hard. After a surgery, they usually take the lymph node, they dunk it into a formalin, something that keeps it good for a long period of time so they can look at it under the microscope, but prevents us from doing all this sort of more higher technology, single cell RNA-seq work. And we have found a way that we can now, and so before it was like literally we'd have to go overnight doing every samples as they came in. Even especially when they turned out to not be Castleman, we could invest thousands of dollars not knowing that, oh yes, the sample, that patient's lymph node actually wasn't Castleman, and we thought for X, Y, and Z reasons it might be. And so we now have ways to do large scale biobanking, cryopreserve the tissue, and still get this out. Right now, I'm just starting to look at somebody who's just had enough samples of patients who have Castleman disease, Unicentric Castleman, don't have Unicentric. And it does look like there are populations of stromal cells that appear expanded in the Castleman disease compared to patients who don't have Castleman disease, but otherwise are inflamed. Another story has been this discovery recently this was the original group in China, but there's been another group in Stanford that has identified this PGFR beta mutation, a mutation in a gene that's important for cell signaling. It's also expressed by these stromal cells in particular. And when this original paper looked at this mutation, they found it was mostly in cells that were not part of the white blood, not part of the immune system. They were not immune cells. Again, suggesting that perhaps this mutation is happening in these structural cells, these stromal cells. And so what's so interesting about this mutation is it's very well known to us. This gene, it happens in the gene, is very well known to us. It's sometimes drive different kinds of cancers, and we actually have FDA-approved therapy that can block it. So when I work in the lab, I can use that same mutation that was identified in a subset of Castleman patients. I can show that I can make cells in culture grow inappropriately when they have this mutation. And when I give them different already FDA-approved commercially available drugs, I can get different kinds of responses in how I make the cells not grow, and preventing the cells growing, particularly for either sunitinib, Sutent, crenolanib, and an old drug, imatinib, suggesting that at least for the subset of patients who may have this mutation, there may be different treatment options available to them that are already available to be repurposed for our patients. So I'm working more to try to describe this mutation. I'm working more to actually make a mouse that will express these mutations in stromal cells so we can see whether we can have an Algernon, a mouse that has symptoms of big lymph nodes that look like Castleman disease using this mutation to prove that it's a cause and not just a downstream thing.
Will that gene be on the list of things that people should test for in the future? Yeah,
right now there's not.
On the recommendation for doctors to know.
Right now it's not there at all. It's still, this has all been our research discovered. I suspect yes, particularly for patients who, and obviously there are costs and insurance approval issues, the practical concerns, right, with doing things in real world in clinic for patients. But assuming you can get it approved, I think it makes sense to test for it up front. If you're a patient who from the diagnosis may have difficulty with resectability, or presenting maybe with comorbid inflammatory disorders. To add it to the list of things you could try later on. So ultimately, I hope this is going to help us to understand the disease. So maybe develop a new test that can more cleanly diagnose it, right? If this is an expanded population of stromal cells, well, guess what expresses certain particular proteins that they can then test for their presence, more routine pathologists. So you don't need to have your sample sent to the big fancy place to get their review done. You can have your local person know, oh yeah, I just need to order that test, and then making an easier call whether it's there or not. And then also to develop new treatments for patients and areas on unmet medical need, and hopefully apply some of this to multi-centric cases as well. So we also need the help of patients to do this, because this all starts on having the ability to access patients' tissues when they get surgeries. So if you have surgeries coming up, please let us know. And the goal would be to try to get a portion of your tissue so that that's not used for the clinical diagnosis, to do this sort of work in addition to other work that we're doing as a larger part of the Castleman's collaborative work. And we've had some success getting other organizations to buy into this and to try to get on board and helping us to fund this research.
So with the gene mutation part, is that something that could actually be like passed down genetically to your children, or to your siblings? Or
I'm describing what are called somatic mutations, so no.
Okay.
They're not germline mutations where this happens in a lymph node cell. Right. So this is a mutation that would have happened to that one lymph node cell, one cell in your lymph node there, and then they grew it from there, as opposed to something that was passed along from families. No, this is considered a somatic mutation, not a germline. The mutation actually does exist in a germline way, and that causes a completely different disease. That has some similarities to Castleman, so that's why I really do think there's a lot of smoke around this idea of it being important, but this is not a germline.
I'm sure this is going to be another stupid question, but in the past, I think, if I'm not mistaken, there's been an increased risk for like cancer for Castleman mutations. Do we know why that is, or if there's is it just from do we have any idea which one do I be at an increased risk for, or how that works?
Exactly. And I should have said this more in the management part of it. That is one of the things that comes into play when we think about taking out lymph nodes from patients, right? Some patients, they hear that there's a risk of transformation, to large cell lymphoma or follicular lymphoma, or risks of developing follicular dendritic cell sarcoma, which actually is a cancer of one of these stromal cells. They hear that and no, get this out of me yesterday. I don't want to live with any risk, even if it's a small risk, get it out. Other patients, they make a different calculation based on how big the surgery is. And so that's an important point just clinically for me to say out loud, because I missed it and you brought it to attention about that's a risk. And you asked them the question is, well, what causes that? And I'm going to, give you a very unsatisfying answer, which we don't know. I can give a few ideas, which is that because of this sort of disorder in the immunologic response that's happening, it's causing these lymph node changes that they see under the microscope, that this will then set them up to receive signals that might make a cell then make a mistake. That's what all these sort of cancers are. It's a cell made a mistake in copying its DNA. All cells copy their DNA to replace what gets lost over time. All cells are like milk in the fridge, they're not good, forever. So they copy their DNA to make new cells. They do that over and over and over again. They make mistakes, just like if you had to transcribe a book over and over again. Young whippersnappers, everyone has these mutations in their DNA. It happens in the context of a lymphoma or any kind of cancer. It just happened where a really important part of the DNA. And so that's one idea about what could be causing it, is that the disorder, or other just maybe your immune system's just not as good at detecting cancers as they come up. Another possible explanation. I'm just kind of confabulating. That's the idea.
Can I add something?
Yeah.
And please correct me if this is wrong. But so one thing about, I think, some of these risk studies, it can be really challenging to know the true risk. And I think a lot of that is in some of these Castleman records, a lot of the times, the way these studies are done is they'll look at insurance claim databases and look for cancers associated with patients with Castleman disease. And oftentimes, I think when you're getting a CT scan or something in your medical history, you might have something such as a cancer noted in your medical record as a possible reason to be doing some of these scans. So some of this is the way that this research is done. There might be there certainly could be very much a risk, but I think some of it, in terms of how they're finding some of this information, risk associated with some of these cancers.
Yeah, it's a low risk.
Yeah.
And so that's exactly right, which is why I don't think it's if I thought it was like a horrible risk that they were absorbing by keeping these lymph nodes in them, we would say, no, never, yeah. But it's the idea that it's a shared patient decision, because like the risk is so low, it's hard to say clearly that this is, and make a clear recommendation. No, you need this out yesterday, even though that's the way someone might feel.
Yeah.
They might feel otherwise. And I think it's still a fair decision because this risk is quite low. The shield is quite low.
That makes sense. Thank you.
I'm going to stop talking because I think you've heard a lot from me.
It's been great, though. Thank you.
Oh, I'm glad. Thank you. And I'm happy to just talk more conversationally. I don't know where we're at with.
Yeah, 5 minutes about, and there's a couple other, I mean, I can pop in the questions from the online folks and we can go back and forth. Somebody brought up a question about, I believe they're kind of asking about a lymph node tumor. What about a lymph node that kind of returns in the same place after resection? Have you seen that? And do you have anything to say about it?
Super rare to have a lymph node return. That's low single-digit percentage is the overall, is my understanding of the overall risk of having that happen.
Okay.
I think the case that I've seen where it happened before is I suspect they had something growing originally. So it didn't actually like recur. It just never got fully resected in the first place. Sorry. And you had a question?
I was going to ask you about VEGF and what role that plays, what other markers you should look to be raised, and what that exactly means, like the neutrophils and everything.
Yeah.
Can you explain a little bit of the basic blood work?
Yeah. So, obviously in medicine and science, everything is some weird alphabet soup. VEGF, vascular epidermal growth factor. It's a fancy way of saying it's something that makes blood vessels grow. That's what it's used for.
And how does that relate to Castleman?
Right, exactly. So its original use, why your body uses VEGF, is to help you if you injure yourself or when you have an infection, to help get the white blood cells to the problem area, right? That's what VEGF is supposed to do, help make new blood vessels to get the blood cells where they need to go, right? Or to help other areas repair after you injured them to get new blood air over there, right? That's what VEGF is supposed to do. It's also, because it's increased during all these problems that the body's trying to solve, and a marker of inflammation. We know the association with Castleman is partly just because it's a marker of inflammation, but also partly because we know that Castleman lymph nodes, in particular, one of the ways they look disordered under the microscope is that they're very vascular, that they have all these new vessels there. This is particularly true for unicentric disease, even over multicentric disease, is that they're very vascular. And that can be one of the complicating factors I didn't mention before of surgeries. And they make a surgeon think twice as whether or not they think that they're just going to be too difficult to, to control bleeding, things like that, because these lymph nodes can be a little bit more vascular than another enlarged lymph node that they were taking out for a completely different reason. And so that's kind of what it's doing in Castleman.
Okay. If it has not been traditionally up in a patient and it is up later, even though they were symptomatic earlier, would that be a flag?
I'm sorry, you're saying it was
like
not,
the VEGF was not up in any prior testing,
and then all of a sudden, that would certainly be a flag, even that something else might be going on, right? And so you can see VEGF elevations with other things like poems, for example, is the classic association with VEGF. But you know, every time you see someone, it's always a complete head to toe. How are you doing, right? Everyone thinks I'm joking when I say that's the most important question I ask them, but it always is. And so that's how you have to take any number in isolation: is how is the patient doing? You know, and you have the totality of this, you know, other markers of inflammation, radiologic studies, and then just decide, well, that's up. I don't know why it's up. I'm going to have to just keep my eye on that, or do we do something about this? And does this spark a broader investigation, because they're also telling me X, Y, and Z things are going on.
And when the IgG changes, how much lower does it need to go before it's a real flag? Because the markers, you know, the ranges mean one thing, and the real ranges of when you intervene is another.
Yeah.
So at what
so none of these markers by themselves are like a reason to intervene, right? The VEGF can be what it is, but I don't necessarily intervene just because of VEGF. If someone says I'm having a great life, I'm doing everything, well, I can make sure that we're thorough, but I don't know if that, and I'm looking for other possible evidence of inflammation or blood count effects. But beyond that, and you know, if that can also provoke additional cross-sectional imaging, if we see other things, maybe a bone marrow biopsy, rather than just doing a VEGF over a bone marrow.
But if your case is changing and your numbers are changing, then you would look at something.
Yeah, then you would start looking, exactly.
And Josh, you had mentioned poems. There was one more question in the chat about, can you discuss briefly the relationship between UC regional, that end, and poems?
Yeah, poems, you know, has not been well described in unicentric or oligocentric disease. It's really thought of in the context of multicentric disease. And this is one of the biggest confounding. You have a poorly defined disease that, again, it's defined based on looking a certain way under the microscope. And so part of the definition of, you know, multicentric Castleman disease is baked in, and it can't be any of these other things, which is really frustrating, right? You'd wish that there was just one positive finding, like this means it's that. And it's not any of these sort of things too. And I think about poems in that same sort of way, because poems is then a different kind of disorder where you have a plasma cell, a different kind of white blood cell that definitely is behaving differently in Castleman disease, but behaves in a way different way in the context of poems, where it's just making copy after copy after copy of itself. You do the look in the bone marrow, you see tons of one kind of plasma cell in the bone marrow of the poems patient. But it makes lymph nodes that look like Castleman disease. And so the treatment for poems related to IMCD is treat poems, which is weird, because then the whole Castleman disease kind of sits on the sideline there. And so gets to the fact that it's a poorly understood disease.
Yeah. Well, great. So I think that was the last of kind of the big questions in the chat. It's 1:01. I think that at this point we're breaking for lunch right out in this hallway, and then after lunch there's a picture downstairs. Is that correct?
Yeah. So we're gonna actually try to do the photo outside. So we're gonna have lunch, stay up here, make a little bit of table, like sandwiches and like cold pasta salad, chips, that kind of stuff. And then with like 10-15 minutes left in the lunchtime, we'll probably shuffle everybody downstairs to do our normal like warrior photo with everybody that's here.
And then we'll have another Q&A panel at 1:45. And I just want to say thanks to everybody on the virtual side, and thank you so much to Dr. Brandstatter for our
And just so you know, Josh will also be sitting on our expert panel. So if any of you have questions you didn't get a chance to ask, or you think about them later, not only will Dr. Center be on there, but so will 4 other physicians. So please think through the things you want to continue to ask. It's a whole hour and a half of time to ask those questions. So we will have more opportunities. Josh, thank you so much.
Yes.
Thank you.
I'm so sorry for talking as much as it is. So if anything I said just really felt like, oh my gosh, that didn't fit my story at all, I'm happy to just talk with you about it. You guys can hear what it is.
Thank you. Very interesting.
I wish I could say I understood everything that you said, but it was.
I think that might require a vitamin green.
Okay.
It's the most tangible that I've heard.
It was the most informative session
Yeah.
of this kind.
Thank you so much.
Thank you. Yeah. I appreciate that.